is just the production of sounds associated primarily with the larynx, but of course also would be affected by other structures. Your nasal cavity has an impact on your tonal quality. Assists with olfaction, meaning of course that your olfactory apparatus is at the top of your nasal cavity. I'm sure this is coming as a shock to nobody that your nose is involved in smelling here. Respiratory pump, we mentioned that that's probably most important for lymphatic return. Not so much venous return, but was more important with lymphatic return, pulling a little bit of that lymphatic fluid back into circulation here. Assist in maintenance of acid-base balance. How does that happen? How does that happen? How can breathing affect your acid-base balance? I'm just stroking my chin here as I wait for people to think deep thoughts. And is it because of oxygen?
Carbon dioxide.
Because of CO2? Why would CO2 have an impact on acid-base balance? Inquiring minds want to know. And you're probably just waiting to be spoon-fed an answer, aren't you? It's like, don't make me think. I'm not here to think. I'm not here to remember stuff. The reason that carbon dioxide has an impact on it is that carbon dioxide combines with water in a reversible reaction. And I'm not going to balance this equation because I'm a bad chemist. Forming carbonic acid. This pen's not working so well. They call it carbonic acid because not only can it dissociate back into water and carbon dioxide, but it can also dissociate the other way. See if this is any better. It can also dissociate into a hydrogen ion, hence the acid portion, and a bicarbonate, HCO3 minus, is the bicarbonate ion. You need, if you're not already doing it, automatically associating carbon dioxide with acid. More carbon dioxide, the more acidic. Less carbon dioxide, less acidic. If you have ever drank or seen a bottle of soda pop, Coke, Pepsi, Mountain Dew, Sprite, you'll see the first ingredient on it is carbonated water. What is carbonated water? Water that has what? Carbon dioxide. Has what? Carbon dioxide. That's what makes it carbonated, all right? What are all those bubbles? What would those bubbles be composed of?
Carbon dioxide.
Carbon dioxide. Give me 1 second here. Yes, carbon dioxide, since we've just called it carbonated water. Oh my goodness. The bubbles are what gas, people?
Carbon dioxide.
Carbon dioxide. And for those of you who have tasted soda before, how does it taste when all the bubbles have gone?
Yeah, flat.
Flat. Why would the taste change? Because it's what?
Less acidic.
Less acidic. When the carbon dioxide leaves, what has left with it? the acid, which is why it tastes flat and dull, because you've lost that acid tang. And the respiratory system is one of two systems that's critical for maintenance of acid-base balance. We will see later that the urinary system will be responsible for long-term acid-base balance by determining how much acid you either retain or eliminate from the urine. And there's some types of acids that can only be eliminated by the kidneys that way, what the metabolic acids like sulfuric acids or nitric acids, all right? But the respiratory system is the system that your body goes to for short-term control of acid-base balance. It can change your acid-base balance like this, within moments, by changing how much carbon dioxide you either retain or eliminate. If I slow down breathing, let's do it the other way. If you slow down your breathing, what will happen to levels of carbon dioxide in your body? They will do what? Go up. And then what will happen to your acid levels? They also go up, which means your pH would be going down, because the more acidic you are, the lower your pH would be. If you were to breathe more rapidly, speed up breathing, are you going to be retaining more carbon dioxide or eliminating more carbon dioxide? If you breathe rapidly, you're going to be eliminating carbon dioxide. And as you eliminate carbon dioxide, you are eliminating what?
Acid.
Acid. And as you eliminate that acid, then your pH would go up. You become more alkaline. So your body can very rapidly adjust pH simply by modifying your respiration rate.
Professor,
Yes.
so what happens if we have a mask on?
Hmm?
And so if we are, so the carbon, the CO2.
That's no
we're breathing it
impact.
back in?
No impact.
No impact?
No impact.
Okay.
That's why, for example, the doctors who operated my knee, for example, were able to wear a mask successfully for 6 hours in a row without any kind of untoward effect. The dentist can wear a mask all day long without any kind of untoward effect. That every healthcare professional out there will wear a mask for 8 hours or longer without any kind of untoward effect. No impact whatsoever. Good to mention that. All I want to say is that if you're like, oh, I can't breathe after wearing my mask for like 10 minutes to get into Walmart or something, you're just a whiny little bitch. Okay, oh, where are we going with this? Okay. Well, the last section here, something not that critical, we will cover this later, but we mentioned that angiotensin 1 gets converted into angiotensin 2 by this enzyme that's called ACE, angiotensin converting enzyme. Well, where does this enzyme occur? The most common place that enzyme occurs is in cells that line the lungs here. So when they're talking about assisted generation of angiotensin 2, it's not involved in any other part of the renin-angiotensin system. It just simply happens to have the place where we find the most common place where we find those converting enzymes. That's just a little memory recall. So let's take a look at the respiratory system. We gotta go back up here to show you here first, because we need to divide the respiratory system into two major regions. We have upper respiratory, and if we have upper respiratory, you can be sure we're also going to have a lower respiratory. In the upper respiratory, what are the components of the upper respiratory system?
Nasal cavity, pharynx, larynx.
Yes, basically everything until you get to the trachea. So the nose, nasal cavity, pharynx, larynx, considered upper respiratory. Then everything down and below that, lower respiratory, the trachea, all the bronchi, the primary bronchi that branch into secondary, into tertiary, into quaternary, 15, 16 times, until you get to the small cell bronchial branches that branch into alveolar ducts, and then the alveoli. You drew, or you labeled some very pretty pictures of this for your lab test here. And this is lower respiratory system here. Upper respiratory is not going to have any gas exchange going on at all, is it? No. No gas exchange. And even a lot of the lower respiratory is not going to have gas exchange, all right? Those areas in a moment we will be calling conducting zones. The conducting zones don't exchange gas, but they do three critical things that you're probably already aware of. They will warm the air, so by the time it gets down to the alveoli where exchange takes place, no matter how cold the air is that you're breathing in, it will be warmed to body temperature. So we're going to warm it, so there's going to be no shock when it reaches the alveoli. Warm it.
It will warm the air.
Warm the air. Here's a quick math question for you here. You are doing some research in the Antarctic. You're breathing in air that is at minus 27 degrees Celsius. It will take it 3.11 seconds to get into your alveoli. What will the temperature be when it reaches your alveoli? Carry the 7, multiply by 4. The answer to that question, 98.6. That's your body temperature. You didn't need to know all that other kind of crap. It's going to be warm to body temperature. I don't care how cold it is when you breathe it in and what kind of false numbers I give you. When it reaches your alveoli, what would its temperature be? 98.6. Assuming your body temperature is 98.6. Doesn't matter how cold it is, it will be 98.6 when it reaches the alveoli. Warms to body temperature. Second major thing that conducting zones are doing, filtering, cleaning the air. Second thing it's doing is what? Cleaning and filtering the air. How do we clean and filter the air? Well, the big ways that we're filtering and cleaning the air is, first thing we need to create turbulent airflow. So the air is turbulent. Why do we want turbulent airflow? Because we want the particles in the air to come in contact with the walls of the respiratory system that are covered with what kind of sticky material? Mucus. Because we want those swirling particles to hit the mucus and then stick. And then how do we get the mucus up out of, with all the particles that it's trapped, all the dirt, debris, how do we get that up out of your lungs? Well, coughing if you are a 1 or 2 pack a day smoker. For other individuals, you have ciliated cells that line your respiratory passageways. That was where you found that pseudostratified ciliated columnar that you were forced to learn pretty much at gunpoint in 109, right, when you did histology, right? All these ciliated cells that in your nasal cavity and in your lungs, your respiratory, are constantly sweeping the mucus towards the back of your pharynx, all right? So every time that you swallow, some small amounts of that are taken in and then digested. That's how you get rid of the bad guys that way, all right? So that's how you clean the air. You create turbulent airflow. And were there structures in the nasal cavity, by the way, that help to create that turbulent airflow? Yes. What were those structures in the nasal cavity?
Nasal cavity, pharynx, and larynx.
Nasal median.
Was the nasal concha, right?
Yeah.
The superior, middle, and inferior nasal concha. They have this swirling shape like this to help to create swirling, turbulent airflow from the get-go. As soon as the air enters, we start to swirl it around. Makes it a very cleaning, effective mechanism. I said, of course, this is a cleaning mechanism unless you're smoking a pack or 2 a day, all right? You've got that kind of money, that kind of coin that you can afford 1 or 2 packs of cigarettes a day. That's like half a paycheck for most people these days here. All right? But eventually the cigarette smoke, especially over time, tends to paralyze those cells. So they can no longer keep it cleaned up. They're no longer sweeping it out of your lungs. So if they can't do it for you automatically, then you're gonna have to get rid of that stuff manually by doing what? By coughing. And that's what tends to lead to that sort of classic cough, or that smoker's cough. Are people aware of this? Have you ever had an apartment? I had one of my first apartments, had a party wall that was probably as thin as, I'm guessing the wall was this thin because I paid very little money. I'm guessing the wall between me and my neighbors was about this thin. You could basically feel the wall move here, all right? I eventually had to move because every morning, like 7 o'clock in the morning, I would hear just clearly, every morning you'd hear this thing. And guess what? He was a smoker. Big surprise there. Now, if you stop smoking, eventually they come back, they regrow, you're going to be fine. But over time, with continued smoking, the abrasions tend to turn the cell tissue type from being simple columnar to stratified squamous. And that's when you're in a precancerous condition. Once you start to convert them into stratified squamous to try to give it some protection, no, you're on that edge of developing cancer. All right, moving on. So this is sort of showing the lower sort of respiratory here. Where we have, well, we'll see this again later, but since I've got this picture up here, you know that the larynx, your voice box, made up of pieces of hyaline cartilage, right? The two most prominent ones you were asked to identify in lab, remember? The thyroid cartilage, the largest one, that tends to have a ridge on it, more prominent for males, quote unquote Adam's apple. No? Nobody?
I remember that.
And then below that, one called the cricoid cartilage, which is the lower one right before you get to the trachea. A nice little gap between those two, which is where you're going to put a tube down if you need to get a trach tube in. So the trachea are then going to go down through the mediastinum, right? Mediastinum, the space between your two lungs here, right? Go down there and then branch into primary bronchi at the carina. That's that little sort of junction between them, where the two primary bronchi, they're going to take into the lungs. The primary bronchi branch into secondary that will take them into the lobes. Secondary bronchi take them into what? The lobes. There are 3 lobes in the left lung. So how many secondary bronchi on the left side?
3.
I'm sorry, did I say left side? What is wrong with me? Right side. Right side has 3. Why does the left only have 2?
Because the heart is there.
Because the heart displaces it. So the left only has 2, all right? And that big lung, or that big lobe of it, has that big cardiac notch on it, right? Where that heart cutout would be. And they will continue to branch into smaller and smaller ones that are going to be kept open with cartilage. We have cartilage, 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 almost all the way down until you get to the small little bronchioles. All right. Now, the larynx is made up of plates of cartilage, correct? Yes. The trachea has C-shaped rings of cartilage all the way down to help to keep it open all the time. All right. And you still have cartilage going down the primary bronchi, secondary, until you get to the small little bronchioles, when they no longer have cartilage, just smooth muscle in the walls to help them control their diameters. And I might as well mention this, as I've got these terms on here right now. Because do you see how they've lumped this into a big group here? Terminal bronchioles. Terminal bronchioles are part of the conducting zones. They are the last of the structures in the lungs where there's no gas exchange. Gas exchange occurs in the little air sacs that we call alveoli. So if a structure doesn't have alveoli, it's not going to be exchanging gases. And the first structures that will contain alveoli are the respiratory bronchioles. That's why they're called respiratory bronchioles, because they actually allow you to exchange gas because of the presence of what? Alveoli. Will you have alveoli on terminal bronchioles?
No.
Bronchioles?
No.
Tertiary bronchial?
No.
Secondary?
No.
Primary?
No.
On the trachea?
No.
Larynx? No. Why bother going with it? Right? Going up, that's kind of stupid, but going down, we're going to have alveoli, everything down here. Yeah. Alveolar ducts have them, the sacs containing alveoli. Yeah. A little bit about the histology, something we've already touched on. It is the respiratory, lining of the respiratory system, part of your mucous membranes. What is the giveaway, the dead giveaway that this is part of your mucous membranes?
Cilia? Cilia?
Not even the cilia doesn't tell you that it's a mucus.
Oh, the goblet.
Mucus, that's all. Listen, campers, sometimes it's really just that simple. How can you tell it's a mucous membrane? Mucus. Lovely, lovely mucus. Through these mucus glands, and you can see these are called goblet cells. These are, when you do a histology section of it here, you see these white cells interspaced with all these ciliated cells. There they are, the goblet cells, whose job is to create what material? Mucus. Now mucus is really kind of like, imagine you take like a Jello powder. Everybody with me on that? You take some Jello powder, and if you just mix a tiny little bit of water with it and freeze it, you get something that's really solid. Like if you're doing like a Jello shot or something, so I've read about in papers. But if you mix that with like lots and lots of water, you just have this runny sort of stuff that really isn't. And the raw material that makes up mucus is this mucopolysaccharide that's called mucin. Don't worry about writing this out, but here's why I want to tell you about mucin. Depending on how much water it's mixed with, the consistency of the mucus can be anywhere from extremely runny to very, very thick. Just depends on water content. And you probably already have some familiarity with this. You know, when you have a cold, there's a lot more fluid in it, then your mucus tends to be a lot more watery, a lot more runny. When you're a little dehydrated, it gets a little thicker. So this is definitely part of your mucous membranes here. Where it talks about the mucous membrane consists of epithelia and the underlying areolar connective tissue that's called the lamina propria. If you're not already sort of familiar with this, for all intents and purposes, every epithelial tissue is supported by areolar connective tissue. It's the most abundant connective tissue in your body. It supports virtually every epithelial tissue out there. Even the ones that make up your cardiovascular system, a thin layer of areolar connective tissue below it. Digestive system, same thing. Right? Would that apply to all areas? Would you find it, for example, under your epidermis? Your epidermis is stratified squamous, correct? And the top layer of the dermis is made up of areolar connective tissue. The papillary layer of your dermis. I know you folks are going, that was 109. Why is he talking about 109 material here? Why is he doing that? It's just to try to bring everything together to remind you there's similarities for what you did. All your epithelial tissues are going to be supported by what? Areolar. That's areolar connective tissue. Sometimes they just call it loose connective tissue. Technically, loose connective tissue also contained adipose tissue and reticular, but adipose tissue is nothing more than areolar connective tissue that's been loaded with fat cells. You take areolar connective tissue, you just load it with fat cells, adipocytes, and now you're going to change the name to adipose tissue. But really, it's nothing more than a modified version of areolar. The mucous glands, the goblet cells, are the ones that are producing the mucus. The type of cells most commonly in pseudostratified ciliated columnar. That was one of your 109 topics there. All right. Don't worry about this difference when we're talking about the oropharynx and laryngopharynx where it says stratified squamous. That's because those are the areas that are continue with your oral cavity, and your oral cavity is stratified squamous. Did you talk at all about keratinized versus non-keratinized back in your 109 days? So there are two distinct sort of families of epithelial tissue, stratified squamous epithelium. The ones on the outside have to contain this tough waterproof protein called keratin. It's a waterproofing protein, very tough waterproofing protein. So when we have a stratified squamous that is on the outside, we need waterproofing, so we have keratin. And all the things from the epidermis, like hair and nails, are also full of keratin. But for the inner areas, like the stratified squamous that lines your oral cavity or the vagina, do we need to try to keep those areas waterproof?
No.
Now, aren't they moist environments?
Yes.
So when we have stratified squamous on the inside, it's going to be non-keratinized. We don't want to waste keratin, if you will, when we don't need waterproofing. Keep in mind the whole idea about waterproofing is to keep water vapor from getting out, not to prevent water from getting in. So again, we've got primarily in pseudostratified ciliated columnar, that's what sort of specialized in your respiratory tract. By the time we get into the bronchioles, we're down to like just simple cuboidal. But here's where it's more important, in the alveoli themselves. When I say more important, does that usually mean more testable? Yes. Because the alveoli themselves have a couple of types of cells. The type 1 cells are the simple squamous that make up the air sacs. The type 1, far and away most common, they are what? Simple squamous. The advantage of simple squamous, because they're so thin, it makes diffusion extremely efficient, very rapid. Are we going to need to exchange gas between the alveoli and the pulmonary capillaries? Yes. Okay. What are the alveoli composed of primarily? What type of tissue? Simple squamous. And the capillaries that cover the alveoli, they are composed of what? Simple squamous. So we have simple squamous, your thinnest tissue, right up against simple squamous, your thinnest tissue. All right. These tissues are fragile, aren't they, right? It's not like stratified squamous. That's your most toughest abrasion-resistant tissue. Protects you against Indian burns. But simple squamous is incredibly delicate, fragile, because it's so thin, you can have rapid diffusion of gases. Oxygen going one direction, carbon dioxide going the other direction here. Now, the other type of cell here, what are called the type 2 cells, produce surfactant. They produce what? Surfactant. Quick question that brings you back to things that you did in 109 again, and you're going to hate me for it again. All right, I can take the hate. All right. Was water a polar molecule or a non-polar molecule? Water. Polar or nonpolar?
Polar?
Why you looking? I'm not.
Water is what? Polar. Everybody. Polar. Water is what? Polar. What do you mean by we say it's polar? That means one side of a water molecule is a little bit positively charged and the other side is a little bit negatively charged. All right. What would the effect of a positive side of one water molecule be? What would its effect be on an adjacent water molecule? Right? Would there be any attraction there? Or?
Yes.
What would be attracted? The partial positive of one would be attracted to what?
Partial negative.
The partial negative of the adjacent one, correct? Right. So for example, I have this here handy. Does anybody have water, just pure water I can borrow? Oh, great, thank you. I'm going to put several billion water molecules on the tabletop here. Thank you for this here. All right? If gravity were the only force acting on it, what direction would gravity pull all the water molecules? Down. Everybody understand that gravity pulls? Down. And it would keep pulling all the water molecules what direction? Down until there would be a monolayer of water molecules, correct? That's what gravity works. Is this what happens? Is it? Let's see. I'm going to put this here. Thank you very much. We'll give it a chance to reach equilibrium for a moment. And then see what happens. And if you can see, as it turns out that it is not being pulled down into a monolayer. Why? Because the hydrogen bonds between them, that's what you find between polar regions, hydrogen bonds, right, are tugging on them, causing them to pull up into a rounded convex structure that we call a drop. Thank you. It's a drop. Water forms drops. What holds water together in drops? Hydrogen bonds. This is an alveoli. Not to scale. Is this a humid environment inside of the lungs? Yes. Because not only does the conducting zone warm it and filter it, but the third thing is it humidifies it. So by the time the air gets down into the delicate alveoli, it is fully humidified. Relative humidity, 100% when it gets down there. Conducting zones warm, filter, humidify. So is this a humid environment here?
Yes.
Which means that will there be at least a microscopically thin layer of water molecules covering the surface of the cells here? Yes. And what are all those water molecules? What is their effect on each other? They are pulling on each other because they are polar. Pulling on each other with what kind of bonds? Hydrogen bonds. And so all the water molecules here are pulling on each other, just tugging on each other, tugging on each other, pulling on each other. And because of all that tugging and pulling on each other, that would cause the alveoli to basically collapse. Would that be a good thing or a bad thing? That would be a bad thing. Makes it very difficult to try to fill this with air if the alveoli have collapsed because of all the surface tension the water molecules have created. In order then for us to inflate the lungs easily, we have to find a way to break down the surface tension. We need basically a detergent to do that. And what do we have that will do that? Surfactant. Surfactant is a detergent, really. It's got a polar, nonpolar, it's a detergent that breaks down the surface tension. What does surfactant do? Breaks down the surface tension to make it very easy to fill the lungs with air. Without the surfactant, what would happen to the alveoli? They would collapse like this. It would take massive amounts of work to try to actually force air in. This is a good time to talk about a little bit of clinical application about surfactant. Everybody ready? Until you're ready here. Surfactant does not begin development until late fetal development. The lungs are one of the last systems that develop. Especially if you're, you're not going to really hardly get any until you get to about 28 week. A normal pregnancy, 40 week. 38 from your last period, about 40 weeks gestation, that's a normal period. If you can get into at least the late 30s, if you can get your pregnancy maybe at least to 36 weeks, you're going to have at least some surfactant developing at that point. Well, when babies are born extremely premature, are they able to produce surfactant?
No.
Are their lungs collapsing like this? Yes. This produces a condition that used to be almost always lethal here, all right? Where you would have what's called respiratory distress syndrome. In the case of a baby like this, it would be, they would call it IRDS. Infant or infantile respiratory distress syndrome.
Is this what we want to
Mm-hmm. Especially this one here, IRDS. Just write on the back. You have room on the back of that one? Yeah. IRDS.
Infant.
All right, which is infant respiratory distress syndrome.
I'm looking at this, it's in my brain, I lived through this. I've been through it, so it's not the one. You look at me, why you not writing?
Because you have lived through this, you know the issues associated with this. Now, if there's a couple things, nowadays, at least when a baby is born prematurely, very prematurely, they actually have an aerosolized version of surfactant they can actually give the baby now, surfactant therapy to help with this. But without this, all right, it takes huge amount of work for the lungs to try to fill. It takes massive amounts of pressure. And has the baby really developed any kind of musculature here? No, the baby, without any kind of assistance, the baby would rapidly fatigue and die on their own. But what they've done in the past, and they would put this baby on a ventilator, a positive pressure ventilator, to force air under. Now, I'm not going to test you on all this little bit here, but this is clinical basis. This is why it's important. They would have to put that baby on a ventilator and force air into the lungs. Force these open. And that high pressure also can do its own types of damage over time here, so that often those people, when they're older, can have their own sort of sets of issues associated with that. Nowadays also, not testing you on this, but if they know you're probably going to have to deliver early because you've got a difficult birth, maybe multiple births, or you've got preeclampsia, whatever your issues are here, they can give mom a shot of glucocorticoid, a steroid, that will greatly speed up the fetal production of surfactant. So nowadays, so respiratory care, more than anything, is what's pushed survival of preterm infants back to the 20-week or so, stage, which was almost unheard of to even a decade or so ago. So a lot of the advancements in neonatal care, prenatal care has dealt with respiratory issues. Can there be, are there other issues with preemies? Yes. All right, but the respiratory is far and away usually the most important sort of one that affects life. Now, adults can also get this kind of condition, all right, if something destroys these surfactant producing cells. Tomorrow morning, there will probably be some patients taken into local hospitals with this condition. Why do I say tomorrow morning? Well, because today is what? St. Patrick's Day. And there will be some people who will be out there who will be drinking way too much. They will pass out. They will vomit. And then they will aspirate the contents of their vomitus. All right? And when you do that, you aspirate the contents of your vomitus, all right? That acid is going to help to destroy these cells, leading to the adult version. They would call it ARDS. Also, relatively high mortality rate here. This often also happens when people have smoke inhalation from fire, where there's fires that are horrible burning stuff like rubber and petrochemicals and all sorts of artificial plastic stuff. Those caustic fumes can do the same kind of damage to the lungs, destroying their ability to create surfactant, leading to this type of respiratory distress, which would also require them to be on a positive pressure ventilation. Oh, and lastly, one thing I'll mention is that the COVID virus also seems to attack these cells. That wouldn't have any impact on you, would it? Nah, of course not. Okay.
Like how late?
We'll see surfactant again later, but I wanted to hit you with it now hard.
Professor, you said surfactant develops in the late stage of pregnancy, right?
Yes.
You said 30 to 40 weeks?
By the time you get, well, it starts late in 20s, but by the time you get into your late 30s, you usually have at least enough to
be okay.
to survive, for the baby to sort of be okay.
Okay.
There still can be other sort of preemie issues, again with heart issues, a lot of other issues, but usually if you get to, let me see if I can find, I don't have it. Let's see if I can find, let's do this. So this is sort of showing surfactant. This is sort of embryonic development here. Showing early on, no real development at all. By the time you get into the around week 20 or so, at least you start to at least develop, they're talking about saccular, at least starting to develop some alveoli at this point here. So once you develop some alveoli at this stage, well, at least you got the potential for gas exchange or breathing here. But they're showing the surfactant generally doesn't start until, again, until you're in your 20s. But by the time you get into late 30s, for example, 34, 36, you developed enough surfactant that your child is probably not going to have that respiratory distress issue like that. If you can just hold on until you get to your late 30s. Early 30s, you're probably going to have some issues with that. Did you have something you wanted to share with?
No, my daughter we went through all that. She was actually born at 35 weeks, so she had a problem. She was only in the ICU for a week. They had her on a ventilator.
Yeah. Did they try this, or they use surfactant therapy too? And
They actually thought I was gonna carry my blood pressure out of nowhere just went high, so I kind of had to get used to it.
Oof.
Because they were gonna be watching me like for diabetes, because I had gestational diabetes. So then the blood pressure came like, all right, now we have to.
Get that baby out.
And I'm like, can we go like, I don't wanna get, can you just try? So they just like, this girl's crazy, but I had to do a week. I was getting crazy, I didn't want to get pregnant.
And she was at 35, right, you said?
Yeah, she was
She was
35.
35 weeks. All right. So take a look. Defense mechanisms. This is a little review here. We've already talked about this to keep all the particulars out of the delicate alveoli here. You got mostly filtration again. It's the job of the mucus and the ciliated cells. But one other thing mentioned is that there are macrophages that also roam the alveoli. There are macrophages that roam the alveoli to clean up anything that's made it through. They call those macrophages inside of the alveoli dust cells. They're actually patrolling the inside of the alveoli. The other things they mention I'm not going to test you on because they're actually in the tissues outside of the alveoli, like in the connective tissue and the capillaries that surround them that act as a protective mechanism. But the dust cells are actually inside of the alveoli themselves. Okay, yeah, head, neck, you've seen this, you know what this is. Yeah, nothing new here. That's a bad first date right there.
Oh my God.
Yeah, our friend set us up together, yeah. Only thing I will sort of point out in here, they're trying to show a little bit in here. Maybe we'll get a chance to touch on later, that you might have touched on in 109, is that many of these facial bones contain air pockets that are called nasal sinuses. Technically, they are paranasal sinuses because they're outside of the nasal cavity, surround the nasal cavity. And this is trying to show a cut through the front here. You've got major, huge ones in the frontal bone here, your frontal sinuses, that often get, when people have headaches, that's right between your eyes there. What sinus can you blame that on? Frontal. There's other big ones in the maxillary bones, maxillary sinus. From mid-sagittal, you can see this little ethmoid sinus in the back here. But, before I move on this guy here, you can see the only thing that's nice about this, you can sort of see, can you get a little bit of the curve shape? This is actually sort of showing the nasal concha here. They're trying to show the curve shape of those bony outcroppings there, that curve shape creating the turbulent airflow. Yeah, nothing else. Hmm? Yeah, nothing there. We did that in lab. Nothing else here. Nothing new there. Oh, we'll mention this here. Just as a rehash, the trachea, once we're beyond the larynx, it's made up of plates of cartilage. We're now into the trachea, which is held open with C-shaped rings of cartilage. Now, is your trachea involved in phonation? A small amount, I guess. Not nearly as your larynx, right? The vocal folds, right? What do the little people call vocal folds? What do the little people? They will call them your vocal cords. That's what the little people would call it. But the healthcare professionals, like you, will call them by their medical name, which are vocal folds. But your vocal folds are the things that vibrate to produce the sounds that you are that you're most familiar with here. But we're not really doing that anymore once we get into trachea. But what this is showing here, here's showing trachea here. And you notice that, what do you have right behind the trachea? The esophagus. The esophagus runs right behind the trachea. Question, why would we not have cartilage all the way around the trachea? Why don't we have it in this little back region where the esophagus is behind us?
It constricts the esophagus.
Yeah, something like that, all right? Is that normally the esophagus is collapsed. If you're not eating or drinking, it is collapsed, all right? But if you are in a hurry to eat something, all right, and you don't want to have time to actually like chew that entire chicken that you're swallowing right now on your way to Weight Watchers, then that massive bolus of food that you're now swallowing is going to do what to the esophagus? Stretch it out, all right? And because we have this opening in the back here, the esophagus, as it expands like that, can impinge on this space that would normally be reserved for your trachea. So it allows you to swallow a sword if you are a circus person, for example, or an entire chicken, for example, all right? That's why it's not a continuous piece of cartilage all the way down. We want it to be open in the back so that you can swallow larger things with that problem. Does that make some sense?
Yeah.
So the cartilage rings, the carina, of course, which is where we get the junction with our...
During our midterm, I have a best friend we've been friends since kindergarten. That's how I remember the Karina, because that's her name.
That's her name? Good one. If only we all had a friend named Karina. All right. The trachea bifurcates, which is just a $20 word for what? Breaking or splitting. But you can charge more if you use what word? Bifurcate. It doesn't split, no, it does what? Bifurcates. So if somebody asks you, what happened to your old boyfriend? You can just say, oh, we bifurcated a long time ago. It's like, wow, you know $20 words. So it splits into the primary bronchi here. One thing that's mentioned here, that it says receptors in the carina elicit a cough reflex, so anything come in contact with them. There's a couple of reflexes that you're probably already sort of familiar with right now. If you have irritants in the nasal cavity, upper portion of the oropharynx, what reflex will that trigger? Sneezing. That will trigger sneezing to sort of clear that out. If you have irritants in the rest of the upper respiratory, really, even parts of the lower, up and through your trachea, your upper bronchi, for example, the irritants in your bronchia, then that would trigger you to do what? To cough. That's going to trigger you to cough. If irritants get all the way down into the little bronchioles, right before we're getting into the alveoli, they don't have any cartilage in their walls. It's going to trigger them to constrict, to try to protect those delicate areas that are distal to them from whatever the irritants are. It might protect those areas, that bronchial constriction at the very last little itch. But that's also going to keep those little alveoli from getting airflow, which is a bad thing. All right, bad thing. So hopefully we'll clear the lungs before those irritants get all the way down there. This is sort of showing, I'm going to keep this up here for about 15 seconds until you have memorized this entire passage. Okay. What should you get out of this, really? Well, here we go into the left side, how many primary bronchi do we have?
2.
2. On the other side, we have 1, 2,
3.
we got 3. All right, they're not showing the cutout for the non. I don't care that you know about the bronchopulmonary segments. That's where the tertiary bronchi would be. I'll be happy if you know that the secondaries go into the lobes. Make me happy, people.
Say it again?
The secondary bronchi are the ones that go into lobes. And since there are different numbers of lobes on the left lung and the right lung, there is one other thing about this that I might test you on. Please write this down. The right primary bronchus, we're trying to show it a little bit better here, is actually wider and a little bit more vertical than the one on the left.
It's wider, right?
Mm-hmm.
Vertical.
Are wider and what?
Wider
And it's more vertical.
Vertical.
Hmm? Wider?
Why?
Oh, why do I want you to know this?
No,
Why is it more wider and vertical?
Because it is.
Because it has more lobe and there's no
I'm
heart.
sure there's a reason for it that I could probably make up, like most of the stuff I do in class here. I'm just not in the mood for just making up stuff, but there is clinical relevance to this because if somebody aspirates, you have a child that aspirates a marble or something like this,
Oh my God.
which is bad, and it's like, okay, now you gotta go looking for it, all right? You're gonna do some sort of bronchial here, lavage, maybe to see if it's in there. Where are you gonna go looking initially? What side? You're gonna go start initially on your right side because it's gonna be easier for that inhaled object
To
to
go down.
go down that side. It's wider, it's more vertical. That's the only reason I'm giving that to you, just for the clinical relevance to that. Where are you gonna go looking?
Yeah, right primary bronchus are wider and more vertical.
Okay. Terminology change here. When we go from the secondary, tertiary bronchi to bronchioles. The bronchioles are like the last couple of divisions of this respiratory tree. And the key difference, you ready for this? The key difference between the bronchi and the bronchioles is that the bronchioles don't have any cartilage in their walls. If there's still cartilage, we're still in the bronchi.
Don't have any what?
No cartilage to keep them open. Only smooth muscle to control their diameter.
You said that's the difference between the bronchioles and the
And
bronchioles.
bronchioles and the bronchi.
Bronchi.
B-R-O-N-C-H-I would be like the divisions of the primary bronchus, secondary bronchus, tertiary bronchus,
So bronchi still has.
bronchi. The bronchi are still going to have cartilage.
Okay.
Now, the truth is, as you go down the bronchial tree, as you approach the bronchioles, as you approach them, you get a greater percentage of smooth muscle, less percentage of cartilage the further down you go. That is true. Until you finally get to the place where there's a branching, where there's no more cartilage at all, and we're changing the name from bronchi to bronchioles.
So where there is cartilage, there's no smooth muscle?
Oh, no, there is smooth muscle there too.
But
There's
there
gonna be
is no-
smooth muscle all the way down. Because there's smooth muscle around the larynx, especially around the trachea, primary bronchi, they all have muscle in the wall here. all gonna have smooth muscle. But by the time we get down to the bronchioles, there's nothing but smooth muscle.
Okay.
And, not gonna test you, but something you probably be familiar with, because there's no cartilage in the wall, when people have issues with bronchial constriction, for example, airway constriction, these are areas that tend to get hit the hardest here. The smaller airways tend to get hit the highest, because the larger ones have too much cartilage in the wall for them to constrict too much. But the smaller ones, less and less cartilage down the road, so bronchial constriction is going to have a greater impact as you get further down that respiratory tree. Something we've already mentioned here is that as you go down the respiratory tree in the bronchioles, the last of the bronchioles that contain no alveoli are called the terminal bronchioles. Terminal bronchioles are the very last of the conducting zones. No gas exchange. They branch into bronchioles that will have alveoli, making them respiratory bronchioles. Respiratory bronchioles. So if I were to ask, I don't know, some sort of evil multiple choice question on the test, as is my wont to do, and were to ask you, one difference between the terminal bronchioles and respiratory bronchioles is that terminal bronchioles do not contain
Alveoli.
A, smooth muscle, B, cartilage, C, alveoli, D, all the above. Can I do that kind of horrible question? No. But of course the correct answer, was alveoli. Because the terminal bronchioles don't have what?
Yeah, she said.
They don't have alveoli. No gas exchange occurs there. The respiratory ones, that's where we first start to have alveoli. The ducts and the sacs, yeah. Alveoli, good service for gas exchange. Nothing else near here. All this is trying to show here is that my alveolus itself, simple squamous epithelium. Notice that they're showing a layer of what here? Surfactant to break down the surface tension, made by those type 2 cells, or surfactant ones. Acts as a detergent to break down surface. They're showing that type 2 cell that's secreting that surfactant. The macrophage doing some cleanup work. So again, these septal cells that secrete surfactant again. Why surfactant? What's it going to do? To decrease the surface tension. Because water is so polar, it tugs on each other with these hydrogen bonds. That's what causes the surface tension. We need to break that down. That would otherwise cause alveoli to collapse. We hate when that happens. Yeah. All right, pleural cavities. In the lab, we'd mentioned when we did that whole respiratory lab, all right, that I said to take a deep breath in. Everybody take a deep breath in. And when you relax, you automatically breathe out because of elastic recoil. All this elastic tissue that surrounds the lung tissue here gets stretched when you breathe in. And then when you relax, the elastic recoil automatically does what? Makes you breathe out. The elastic recoil is always pulling what direction? In. Elastic recoil is pulling what?
And
In. Push out as much air as you possibly can, everybody. Get all the air out, get rid of your expiratory reserve volume until there's nothing left but residual. Push it all out. Go, push it all out. Now relax. You'll notice after you pushed everything out and you relax, you automatically do what? Breathe back in a certain volume. Why? That's because the rib cage expands. You compressed your rib cage when you pushed everything out. And the anatomy of the rib cage expansion tries to do what? Pull what direction? Outward. So the reason that you stop breathing where you do is that's where those two forces are equally counterbalanced. Where the force of elastic recoil pulling in is counterbalanced by the rib cage expansion that's trying to pull what direction? Outward. Which means that there's going to be a tension between those two layers. So in the space between the two pleural membranes, in that pleural cavity, there's going to be a partial vacuum inside there. Negative pressure. We will get to that in a second here. So we have this pleural cavity here. And you'll get a chance to sort of see this better when you do your fetal pig dissection. Many of you probably already noticed that when you opened up the thoracic cavity that the inside of the rib cage was shiny, nice and smooth and shiny, right? That was the parietal pleura. The outermost pleural membrane is on the lining of the rib cage. But you'll notice that the surface of the lungs themselves was shiny, like there was a little membrane on the lungs themselves. Which pleural membrane would that be? The visceral layer. You've got a visceral, a parietal. Because you cut into that, did you break the seal between the two membranes? Yes. Your poor little fetal pig, did you collapse its lungs then? Yeah. Poor little guy. All right. Oh, let's see. Just some definitions probably worth knowing. When they talk about external respiration versus internal respiration. External is all about getting the gases in and out of your lungs. External is what's happening at the lungs themselves, between the alveoli and the pulmonary capillaries. That's external respiration. Internal respiration occurs what happens at the system, at the tissue level. There's still exchange of gases going on, right? In internal respiration, that's between systemic capillaries and the tissues and cells of your body. And how do these gases move? By what process? Diffusion. Always by what process? Always diffusion from areas of high concentration to areas of low concentration. When they talk about pulmonary ventilation, to ventilate, we're talking about airflow. That's different. We talk about ventilation. Respiration is just about gases and the gas exchange. Ventilation is about air movement. So pulmonary ventilation, the movement of air, inspiration versus expiration. Why does it say that expiration is normally passive? What's powering expiration? Diaphragm? No. Diaphragm is powering inspiration. Almost every inspiration, for all intents and purposes, inspiration is always active. The diaphragm is the major one. The internal intercostal muscles are the other major respiratory muscles. They pull your rib cage up and out, your diaphragm pulling down. So, what normally powers expiration? Elastic recoil. Elastic, genau. Elastic recoil.
You said that powers expiration?
Expiration.
That's expiration. Everybody take a deep breath in. Your diaphragm did most of that work. as well as the intercostal muscles. The internal ones are the ones that pull your rib cage up and out, right? When you take a breath in, what do you feel happens to your rib cage? You can feel it pulling outward, right? Because you're creating a partial vacuum inside here. Your diaphragm is pulling down. That's creating a vacuum that's going to suck air in, right? When you relax, what happens? Well, after you breathe in and you relax, what happens? You automatically breathe out. What powered that? The elastic recoil. The fact that when you breathe in, you stretch, you spend some of the energy stretching all these elastic fibers. When you stop breathing in, the elastic recoil automatically makes you breathe out, which is why expiration is normally a passive process.
Which one was inspiration?
Active.
Oh.
It's almost always going to be active.
No, what will cause inspiration?
What would cause inspiration? The main thing, funny you should ask that, you're getting a little ahead of ourselves here, but that's okay. Most people think that the probably most important thing that triggers respiration, you to breathe, is the need for oxygen. Didn't you come into this class with that assumption, people? Didn't, at least if you had an assumption, didn't you assume that's why you breathe? Because you need what? Because you need oxygen? The big thing that makes you breathe is levels of carbon dioxide. That's the main thing. Your body will only make you breathe, it'll only increase respiration if your oxygen levels have really plummeted. Normal conditions, you'll see that under normal circumstances, you always fully oxygenate the blood that's leaving your lungs. Always, fully oxygenated. No matter how hard you're working, it's always full. The key issue is how much carbon dioxide you're getting rid of, because if you retain carbon dioxide, you are retaining an acid. And those two things, carbon dioxide and acid, go hand in hand, especially when you're talking about control of respiration. Control of respiration, acid and CO2 are going to be the major things. So to answer your question, what makes you breathe in? The need to get rid of carbon dioxide and acid. Do you need verification of this? Well, I'll give you verification for, all right. So here's what we're going to do as a class for a minute here. I'm going to have you breathe deeply and rapidly for just 30 seconds. Don't start yet until I tell you. You're going to breathe deeply and rapidly. As you breathe deeply and rapidly, under voluntary control, what will that do to your levels of carbon dioxide that are left in your body? Will you have more of it or less of it?
Less.
You're less. You're blowing off carbon dioxide. As you get rid of carbon dioxide, what is that doing to your acid-base balance? I'm getting rid of acid, right? Which is going to do what? Make you alkaline, right? Now we're saying, if you were too acidic, you would do what? Breathe faster to get rid of the acid. If you're too alkaline, you'd expect that your body would make your respiration rate do what? Go slower, all right? To retain carbon dioxide, as you retain carbon dioxide, you would be retaining acid. So we're going to do that experiment. In 5 seconds, we're going to start. When I tell you to stop, just pay attention to what's happened to your breathing rate at the end of the 30 seconds. And go. Deeply, rapidly and deeply. Rapidly and deeply. Has to be both, rapid and deep. Rapid and deep, keep going. Rapid, deep, rapid, come on. Faster, deeper, fast, deep, fast, deep. Come on, 10 more seconds, go. Fast, deep, come on. Fast, deep, fast, and deep. Okay, now relax and see what happens. Dizzy, because you've just been put into, by breathing rapidly, you've gotten rid of what? Acid, and you put yourself into a respiratory alkalosis, and that's what you're feeling there. That's some of that, all right? Now, how did that affect your respiration rate when I said relax and stop? What happened? It slowed down, right? If you did it heavily for a while, in many cases, your respiratory drive would stop altogether for a little period of time. Did that happen to anybody in here? Because it happens to me when I do this. I've been doing this a long time, so I know how to do it without passing out. But it's a weird feeling to like be breathing, okay, now you relax. It's like, I'm not breathing. I'm not breathing, and I have no desire to breathe. It's a very strange feeling to not want to breathe for a period of time, all right? Why don't you want to breathe? Why did your breathing slow down